guys, so today we're going to talk about more alterations of function of the cardiovascular system. Now, next in the notes is thrombus and embolus, but we've already spent quite a bit of time talking about that when we were talking about blood. So what I'm going to do is talk for a minute about Raynaud's phenomenon. Okay. In someone who has Raynaud's phenomenon, or some people call it Raynaud's disease instead, it is characterized by attacks of vasospasms in places like the fingers and the toes. So in the extremities, you'll get the spasming of the vasculature, which can lead to pain and change of motion. Now, that spasming can be brought on by a variety of things, but very often people get vasospasms in response to the cold or sometimes in response to stress. So when someone has Raynaud's phenomenon, let's use cold, if they go out in the cold, the spasming through the vasculature in their hands, for example, would cause a lot of pain through the hands, kind of stiffness, change in their range of motion and mobility, and sometimes the skin turns cyanotic. It'll turn a bit bluish or purple. The treatment for this obviously would be to avoid whatever your trigger is for an attack, but if that's not possible, they can use things like calcium channel blockers or other vasodilators, right? So we can use things in the nitric oxide family and other vasodilating drugs or calcium channel blockers. And what they're going to do, right, each of these, what they have in common, is they're going to kind of open up the vasculature a little bit. They're going to allow for vasodilation. That's going to decrease resistance to flow and try to increase the flow to those areas to diminish the feelings of pain and obviously to reduce the appearance of that bluish tinted skin. Okay. So now I want to spend some time talking about atherosclerosis, and I'm going to link it to coronary artery disease. So first we want to talk about lipids. Okay. All right, so when we eat, we have different options for foods that we'd like to eat. So we have things like carbohydrates, you have proteins, and then you have fats. Okay, you need each of these nutrients in certain amounts to support not only your metabolic function, but also things like rebuilding cells and tissues and things. So we need a fixed amount of fat. And there are different types of fat, of course. You have saturated and unsaturated fat. But I want to talk about cholesterol in particular. Cholesterol is a type of fat. Where do we find cholesterol? Some of the foods that you eat contain certain varying degrees of cholesterol. So for example, eggs have a higher amount of cholesterol than some other foods. Certain meats have higher amounts of cholesterol. So cholesterol, certain types of cholesterol, I should say, are known to contribute to the formation of these kind of lipid-laden macrophages that are forming what's called a plaque. So let's look inside an artery. You would have the formation of kind of this plaque on the arterial wall. And what that's going to do is then it's going to hinder the ability of blood to flow through the artery. So it's going to drive up resistance to flow in that particular area. Obviously, the bigger the plaque, the greater the resistance to flow. Okay. So some of the risk factors that are associated with atherosclerosis would be things like age and smoking and hypertension. But some of the other risk factors associated with developing atherosclerosis are an increase in LDL and a decrease in HDL. Okay, so then we want to know, what do these words mean? Okay, so LDL stands for low density lipoprotein. And HDL stands for high density lipoprotein. Okay, so then we want to talk about what these are and why they're important. Okay, you also have, I'm just going to mention another marker called VLDL. The V just stands for very low density lipoprotein. There's also ULDL, ultra low density lipoprotein. Okay, so let's talk about what a lipoprotein is and then how it's related to atherosclerosis. So let's start with what a lipoprotein is. We remember that our plasma is mostly water, but cholesterol is fat. And what do we know about oil and water? They don't mix, okay? So when you make salad dressing, for example, you have vinegar, which is aqueous, it's water-based, and then you have your oil on top of it. You shake them up or you whisk them together to get them to temporarily kind of come together to make your salad dressing. But if you leave the salad dressing out on the counter, it's going to separate, okay? So fat and water, they don't get along, okay? So when we eat cholesterol and it passes through the wall of the small intestine, it then has to be transported in your blood plasma, but that presents a problem. What should happen is as the fat moves into your plasma, it should kind of clump up and go nowhere, but that's not good. That's not what we want. So we need a mechanism to carry the cholesterol around in some fashion that is agreeable to this very aqueous environment. We get around that by using a lipoprotein. So the lipoprotein is unique in that it has elements of it that are soluble in water, yet can kind of still bind the fat. So lipoproteins offer us a mechanism for transport of fats like cholesterol, okay? The low density refers to the fact that the protein is at a lower density. So there's lower density of less protein, more fat. And I'm oversimplifying, but that's okay. The high density refers to you have a higher density of protein in the molecule and less fat, okay? So I know it's confusing. Everybody thinks low should be the good cholesterol, but actually this is the bad one. Whoop, I should learn how to spell bad. And this is the good. Okay, so when you get blood lipid levels assessed, you'll get a couple of different data points assessed. All right, so you would get, say, your triglyceride level assessed. That counts as a blood lipid. Then you would get a marker for something like total cholesterol. And that's exactly what it says it is. What is the total amount of circulating cholesterol that is present in your blood plasma at that time? Then you can also measure your circulating LDL and HDL, and then you can take a ratio between them. And obviously you want less LDL and higher amounts of HDL. Okay, so the treatment for atherosclerosis is if it occurs. So first of all, we should talk about why it's bad. Okay, so it puts you at risk. Atherosclerosis will put you at risk for elevated blood pressure, heart attack, and stroke. All right, so how can we treat it? All right, so first thing would be lifestyle changes. You'd want to decrease your amount of cholesterol intake and saturated fat intake. Okay, for some people, they can treat with anticoagulant therapy. Statin drugs. These kind of fell out of favor for a while for various reasons. Sometimes if there's a significant occlusion of something like a coronary artery, you could do an angioplasty to kind of remove the blockage and restore flow through the artery. Niacin treatment, which will lower, in some cases, LDL cholesterol. They have certain drugs that are classified as those that block or hinder, I'll just make like a negative sign, cholesterol absorption. So if you're not absorbing it, it's going out the back door. So there are a variety of different treatments to try to get around the cholesterol issue. Why is atherosclerosis so dangerous? Because you could have a buildup of these kind of lipid-laden plaques in your coronary arteries. And that's one of the things that can cause coronary artery disease. Okay. So remember, we have 4 coronary arteries. Okay, so we have 4 of them. So if you think of your heart almost like a box, you have ones that feed the anterior aspect, posterior aspect, and then left and right side aspects of the heart. So we have 4 major coronary arteries. What those coronary arteries are actually supplying blood to, right, is really that muscular layer, the wall, the myocardium of the heart. I mean, it's the whole wall of the heart, but really this is the muscle piece, and this is the nuts and bolts of it. So the muscle cells of your heart need to contract and relax with at a steady state, whether you're awake or asleep, for the rest of your life. So this consumes a lot of oxygen. So you need constant blood flow to the myocardium. If you block blood flow to the myocardium will lose its ability to pump because it's not getting enough oxygen. It's not able to produce ATP to drive contraction. It's not getting the nutrients to produce ATP to drive contraction. If you block blood flow to the heart, you're putting it under what's called ischemic conditions, which means you're going to have a decrease in blood supply to the cells. If you do that for long enough, cells cannot survive long periods of time without oxygen. So this can cause infarction, which can lead to localized cell death. So when someone has myocardial infarction, that tells us that there's been damage to the myocardium in the forms that the cells are now non-functional. Approximately 125,000 people die each year in this country from myocardial infarction. Now, the risk factors are very similar to the risk factors for hypertension, and that should make sense, right? We want to try to do things that are heart healthy. So certain risk factors, again, same speech as it was for hypertension, they're non-modifiable, right? So things like your age, your gender, your family history, you can't get around. Those are non-modifiable risks, but something that is modifiable is something that you can change. So things like diet, you want to decrease your blood pressure where possible, stop smoking where possible. Obesity and sedentary lifestyle is a risk factor, so you want to modify your level of estrogen, okay? When someone has coronary artery disease, okay, so the main trouble here is if you have decreased flow in the coronary circulation, right, you can have that occur within 10 seconds of an occlusion or a blockage of the coronary artery. Then the myocytes, the cells in the myocardium, can survive for a little bit without oxygen, but eventually, okay, if perfusion is not restored, you'll have cell death. And that can occur in approximately 20 minutes under ischemic conditions. The persistent sign that someone has an issue with the myocardial function is they have angina, which is chest pains, but that's after issues are already started. So the kind of preamble to this is that you don't necessarily have signs and symptoms of a progressive buildup of a plaque in your coronary artery until potentially it's getting into a danger zone where now you have chest pains and potentially could lead to cardiac arrest. So initially your heart's going to get the message that it's not getting enough oxygen, so it's going to pump harder, okay? You may also hear in initial signs some pulmonary congestion, because if the heart is not pumping with the correct efficiency, you might have backup of blood into the pulmonary circulation, okay? All right, so stents, you have a bypass graft. You're putting a stent in, it's really just an easier fix to restore flow. A bypass graft is they're removing the area that's been damaged and then grafting a new piece of the vasculature to restore and rebuild flow. With myocardial infarction, myocyte death will occur. Once someone's muscle cells die off, unfortunately, necrosis is going to occur. You're going to have a death of those cells, and those cells do not regenerate. Muscle cells don't do a great job of regeneration, and if they're dead, they certainly can't regenerate. This will be accompanied by if someone has myocardial infarction, severe chest pain, okay, will be accompanied by an irregular EKG, which is easily measurable in a fairly non-invasive fashion. If symptoms progress, cardiac arrest, which you can certainly assess on an EKG, and then we can assess cardiac enzymes. So we can look at troponin I and troponin T. So those are two of the three cardiac enzymes that we can assess. If these rise, it can indicate potentially the severity of a cardiac event. What are these? Troponin, we remember from when we learned muscle contraction in AMP1, is a regulatory element. These are regulatory proteins that are involved in muscle contraction. These will change when someone's had a heart attack, when someone's had a cardiac event. Okay, so in a situation where someone is potentially complaining of chest pains, right? Oftentimes, in an emergency situation, they'll give sublingual nitroglycerin. So you have someone that's complaining of chest pains, right? In an emergency situation, you can give them sublingual, under the tongue, nitroglycerin. What nitroglycerin will do is will vasodilate fairly quickly. And by doing that, by vasodilating, we're trying to relax the smooth muscle of the coronary arteries and possibly restore some flow. This is something done quickly, then we can obviously, a further assessment would have to be done, okay? If someone takes Viagra cannot be taken with other nitrates for chest pain because Viagra is also a vasodilator. Viagra is a treatment for erectile dysfunction. So the way that it works in that regard is if we can relax blood vessels that service the erectile tissue of the penis, then we can restore flow to the penis so that a male can both achieve and maintain an erection, okay? So that's how it's used to treat ED, but if a patient takes Viagra and then takes nitroglycerin on top of it, it will cause their blood pressure to drop precipitously, which is very dangerous, where the patient can go into circulatory shock, okay? Following assessment of potential cardiac arrest associated with a heart attack, you would also want to look at management after the patient is stabilized. Perhaps they need statins, perhaps they need ACE inhibitors, etc., to lower blood pressure. Obviously, they would need rest and time for recovery, and any analgesics to continually modify their pain. Okay. I'm going to stop there. When we come back, we'll get through pericarditis and valve disorders.